Hello and welcome to another Philips-hosted webinar, International Learning from COVID-19. My name is Fan Chen. I am the Clinical Manager of Respiratory Care, Philips SRC APAC. Philips invited 11 speakers from China, France, Italy, Spain, UK, and USA, who have been dealing with severe COVID-19 patients on the front line. Our speakers today include Dr. Mark Elliott. He's the chairperson for today's webinar. Dr. Elliott is the consultant physician in respiratory medicine at St. James University Hospital, Leeds, UK. Professor Stefano NAVA, professor and chief of the Respiratory and Critical Care Unit, Santa Sola Hospital in Bologna, Italy. Professor Paolo Pelosi, chief professor in anesthesia and intensive care, director of the specialty school in anesthesiology at the University of Genoa, Italy. Professor Nicholas Hart, director of the Lane Fox Respiratory Service at Guy's and St. Thomas, professor of respiratory and critical care medicine, King's College, London, UK. Professor Haibo Qiu, chief physician, doctoral supervisor, professor of Institute of Critical Care Medicine, Southeast University, China. Professor Chun Pang, deputy chief physician, professor of Institute of Critical Care Medicine, Southeast University, China. Professor Julian Pottecher, specialist for anesthesia and intensive care, University Hospital of Strasbourg, France. Professor of Translational Medicine, Faculty of Medicine, University of Strasbourg, France. Professor Antonio Torres, Chief of Respiratory Intensive Care Unit of Hospital Clinic, Professor of Medicine at the Faculty of Medicine at the University of Barcelona, Spain. Associate Professor Manuel Lujan, Consultant in Respiratory Medicine, Hospital Sabadell. Associate Professor at the University Autónoma, Barcelona, Spain. Associate Professor Joshua Farkas, Critical Care Consultant at University of Vermont Medical Center. Associate Professor of Pulmonary and Critical Care Medicine at the University of Vermont, USA. Professor David Hui, Associate Director, JC School of Public Health and Primary Care. Director, Stanley Ho Center for Emerging Infection Disease, Hong Kong, China. They will be sharing their best practices, different approaches, and other useful information to help clinicians around the world manage and fight the COVID-19 pandemic. Now, I would like to hand you over to the chairperson, Dr. Mark Elliott.
Welcome, everybody. I think just to sort of set a little bit of background, not that a huge amount is needed, that I don't know about all of you, but I'm certainly being bombarded by numerous guidelines about how to manage this condition. These are based on the literature using conventional sort of scoring systems, but the reality, I think, is that COVID-19 is actually a new disease and that some of the things that are being extrapolated from previous data may not apply. So what we've done is brought together a panel of experts from around the world who can share firsthand their experience, because I think in the absence of data, then day-to-day first-hand experience is the best that we have to go on. I think it's very important to note that what is going to be said has not been peer-reviewed. It reflects the opinions of individuals and groups of individuals, and it's based upon personal experience. But certainly the first webinar went down extremely well, and people found that very, very useful. I'd like to say thank you to everybody for taking time on a Saturday. I guess at the moment the distinction between weekdays and weekends is becoming somewhat blurred, but thank you for giving up your time to share your experience. And a particular special thank you to Stefano NAVA, who has tested positive for COVID-19 and is currently experiencing the symptoms and certainly not getting worse and hopefully getting better. So Stefano, particular thank you to you for coming and sharing your experience. We've got an agenda to go through that we will stick to loosely, and the whole idea of this is that everybody will chip in and share their experience. And where I think we should start is with the phenotypes of this disease, because one of the things that's become apparent is, one, that it is not just a homogeneous condition, and secondly, that it may differ quite significantly to other conditions that we typically treat with ventilation. And Nick Hart from London has very kindly agreed just to kick us off on this topic. So Nick, over to you.
I can't tell you how much I appreciated the first webinar that was set up. And the reason it was helpful for us in the UK was that Stefano gave us the heads up on what we were going to expect. And I think I can't say the amount of advice and intelligence that he shared allowed us to plan. Currently, in our intensive care unit, we have 53 invasive mechanically ventilated patients with COVID-19 and 14 that are recovering. So we've got a vast number of patients that we're currently looking after. And I think the first slide was actually a slide I made up afterwards to share on Twitter, after Stefano had really given us the idea about the waves of patients coming through, and in fact really drove us within the UK to think about how we're going to treat this condition. I'm going to go on to talk about how we're doing it in terms of looking at phenotypes, and I hope that will be supported by others and what they present. But really, I just want to say that this slide, Stefano, drove us in terms of the direction of travel, and for that we are grateful. So in fact, we've now had published, which was published yesterday, the NHS England guidance on patients with COVID-19 presenting with acute hypoxic respiratory failure. And we've used the RAG rating, the red, amber, green rating, in order to identify patients so they get the treatment that we feel is most appropriate. Now, interestingly enough, in our hospital, we have not used much CPAP. That is not because we're adverse to using CPAP, but the patients we are seeing come through appear to be in a rapid deteriorating pattern. Yesterday, the emergency department, we've got patients coming through, and we've actually intubated 12 patients in the last 24 hours. So I'm sure that's everybody else's experience so far. And so our experience actually using CPAP currently is quite limited, but this was brought in to make sure that patients were not necessarily going to receive CPAP, but we were actually had an escalation plan in place. And we just said it should be used as seeding of treatment to avoid intubation and facilitate extubation possibly. Now, I think this is really important and something we've driven in our hospital, but also driven exceptionally across the way that NHS England views how we are managing patients. We have linked together with our acute care physicians, our elderly care physicians, and our palliative care physicians in order to come up with a sensible, thoughtful, considered approach to escalation of care. And in fact, the NICE guidance, which was released last Saturday, says we should seriously consider about escalation with a clinical frailty score that is greater than 5. And that's for the obvious reasons. This is a very serious condition if you develop hypoxic respiratory failure associated with it. During the view of these patients as they've come through, I think it's not surprising, and again, this came from discussions 2 weeks ago, but we've got an elderly group of patients with a viral pneumonia and a pneumonitis with significant comorbidities. We've got a middle-aged population, which are the average age for around 50, coming in with a viral pneumonia and a pneumonitis. And we've got a young cohort as well attending in their mid-late 20s, perhaps into their early 30s. And that's another group. And these guys don't have any comorbidities. Now, the clinical phenotypes we are really focused on, and part of the research and the data we're collecting now on admission is about age, comorbidities and frailty. And obviously, as time goes on, we hope to be able to present that data. But I'm sure, as others have seen, there's pathophysiological observations. Yeah, we have people with a pneumonia and people with a pneumonitis, whether it be on the CT. But when you look at the post-mortem examinations, and this was a personal communication from Franco Laghi, which he had translated of a post-mortem report, which was from Guangzhou in China, there was the idea of a pulmonary vasculopathy with thrombus within the vessels and evidence of accelerated and early fibrosis. And I think that's going to be part of the phenotype of patients we see. Now, the reason I say that is we got a number of observations that we've had, and that's the folk who have been on NIV or CPAP for a number of days, who then have deteriorated, who've then required intubation, and they've had a low lung compliance. They've got very, very stiff lungs and unable to ventilate. And in fact, they've been in their local hospitals, they've received a barotrauma, developed pneumothoraces, and been transferred to our unit for ECMO. So I just wonder about these patients that are self-ventilating with these high tidal volumes and high respiratory rate for a considerable period of time, developing patient-induced lung injury. It's interesting, yesterday, intubating a patient who was severely hypoxic, that when you intubate them, the compliance of their lung, it's not a really stiff lung. You don't get the feeling this is a very stiff system. And I think it's what we do to that system at the early stage of protecting it is going to be paramount to seeing recovery in the patients. Again, these are just all clinical observations. They are not based on any data, but we've all got experience now of this. So like everybody, I think there's a clinical spectrum. It's parenchymal lung disease as well as a pulmonary vascular component. And this may explain the differences between the treatment options that we can use. And again, bedding back to the idea of on intubation, you see these folk who have a compliant lung, which one would imagine is an inflamed lung, which then hasn't got any evidence of a fibrotic picture. And so I'm actually now considering that, although I know folk are using CT imaging, but perhaps we can determine about the consolidation about the viral pneumonia, the early lung fibrosis, and whether we can pick up those folk that actually don't have much in the way of CT changes or limited CT changes, and perhaps they have more of a pulmonary vascular predominant disease. That's been my observations over a rapid learning experience. And I just want to say again, Stefano, thank you, because you help with our preparedness for this incredibly challenging time that we faced over the last few weeks.
Thanks very much, Nick. Before opening it up to a wider discussion, Paolo Pelosi, would you like just to say a little bit about CT imaging? Because I think that would help us perhaps just to understand this a little more clearly.
Now we started the first intubated patient in Genoa on February 29, and actually we have 3 ICU on 2 floors, so we are very well organized. So we're very large. Actually, we decided to concentrate patients in very large ICU, and actually we have almost 60 patients intubated, and we have almost 100 patients around with helmet CPAP. This is actually our situation in our hospital, and of course then we have all the others in the other hospital in the region. So we decided after the first 9 days, that reflected exactly the phenotype showed before. So all the patients, we did not know exactly what to do. We were a little bit confused. And then we followed almost what was shown before. And we decided against some other view that consider CT scan almost unuseful in this setting, to organize in a military way the CT scan. So we are doing almost 20 CT scan a week. Of course, not all the patients, but we try to do most of them. And we also organize for CT perfusion. And of course, lung echo and lung cardio, but this is more obvious. So what we are finding is almost, these are, again, is not review, is just the collection data which is coming up. three phenotypes. The first you see on the left, you don't see because the image is a bit dark, but there are these gray zones typical for COVID and not much atelectasis, not pleural effusion. So these patients are characterized by very high compliance, they are hypoxemic, they respond to PEEP, but they are not recruitable. So the improvement of PEEP is likely due to mechanisms that are not related to recruitment. And I agree with what was said before, that these were the patients who had not much CPAP before. So at the beginning, we had most of these. Now we are going to the phenotype 2 and 3. So more similar to RDS. There is the phenotype 2, which is half and half. Some like the conventional COVID-19 and more likely to the sort of kind of RDS. So because in the phenotype 1, there is not much edema. It's just lobar, this gray zone, which looks not recruitable in the lung. The phenotype 2 is half and half, and you see the phenotype 3 is more similar to RDS, and some of them, they are even clear atelectasis. So, and these are more and more likely now, because now we are recruiting patients after 5, 6, 7 days of helmet, and so the phenotype is changing. So that's, I was saying, we have to try to do it as early as possible, but even if it's early, it's not early, because now it's at least 5 to 6 days. So I absolutely agree with what was said before, that longer we keep this CPAP, if the patient responds, okay, but if they do not clear respond, we are going to the phenotype 3. And I agree, this phenotype 3 is very hard. This is not the COV, it's a COV modified with probably self-induced lung injury or something else. So we have these three phenotypes, and then I think that CT scan helped us to learn a lot of things. First of all, that the disease is not homogeneous, as we believed before. The disease is not like the CT scan as in non-intubated patients that was some people collected. And now we are doing also some COV non-intubated, which of course they have no atelectasis, a few, but also some of them they have. So we have to analyze also this. And the third point is that we can decide different therapies. So if we learn, for example, phenotype 1, we never exceeded very high level of PEEP, maximum 13, 15, but the improvement in oxygenation was not due to atelectasis. So while the others could be proned or treated with the conventional, interestingly, the phenotype 1, if you to set PEEP according to the driving pressure, for example, the PEEP is lower. So, but oxygenation is going down. So it's completely, you don't have to follow the conventional rules for RDS, which apply for phenotype 3. So this is the first point. The second point that we learned after, unfortunately, one case, is this thrombo was mentioned at the thrombosis. Very, very important. We found this, we did not know that the Chinese were at the same observation, and but then we found this. And now we do, when the patient is deteriorating, because you know at a certain point they reach this level 10, 12 of PEEP, they don't improve, they stay at this. When they deteriorate, we have two possibilities. Or we are going to another phenotype, so the recruitment like this, very few, but then we started to do angiotac. And this was, for us, was absolutely surprising. We found almost 25% with even thromboembolia, even that we look also the echo, but was very, very important at the angio-CT, and even microthrombosis. So the radiologists that usually, they never check for if the microthrombosis, they never write anything, or they don't. In this case, they write microthrombosis, so it means that it's more than microthrombosis. And so that's why now we are trying to do a very clear protocol for coagulation that is very, very important. So perfusion is very important. And the third point for CT is that we started, I have no time now to put this, but we start to do the CT scan in patients which were extubated. We extubate, we put the helmet, or in some cases they don't keep the helmet, we put positive pressure in the ICU. I fully agree before was written MPPV mainly in the ICU, not outside. And okay. Day 1 today, then I organize a unit just next to our ICU under our control, in which we have non-intubated patient after extubation. And we are doing CT scan again. And the CT scan after extubation In patients that more or less you discharging infectious disease, breathing 75 PO2 in air, not dyspnoic, is very bad. It's very, very bad. And I think now we have to analyze that, but looks like fibrosis or something else there. Even if the swamp from the bronchoaspirate that we always do before extubation is negative. Even if it's negative, the lung is not normal. So this is something for pulmonologists, I think, that these patients should be followed in the future for CT scan, for pulmonary function test, for even coagulation. So the issue is that the phenotypes, not only clinical, but also from the lung, are very different. Probably the non-invasive ventilation time before may change the phenotype, but not in a good way. The third one, that there is a major problem, not only for the lung, but also the vascular side, pulmonary thrombosis, and we use thrombolytic, but also microthrombosis. And this damage of the lung can be maintained even early, at least, because of course we have not a follow-up at this time, after extubation. It's something more complex. I think that if we can summarize, COVID-19 is a double killer when you intubate and after extubation. So it's a very, very dangerous serial killer.
Thank you very much, Paolo. So in a moment, we'll go on and sort of explore the whole role of non-invasive ventilation. But is there anything that anybody else wants to say about phenotypes?
This is Tony speaking. Okay. Well, I like this approach, Paolo. The problem, but for small hospitals or regional hospitals, even for university teaching hospitals, now we have 120 patients ventilated with COVID in the hospital. Is 750 beds. So as you can understand, this is a mess. And my question is, because I have followed the literature very closely, and even our own cases, that we have 50 ARDS with all the data, that for phenotype, the patients that evolve for phenotype 3, there is a decrease in lymphocytes, there is a decrease in CD8 counts, and alterations in ferritin. This is one issue. It is important for those physicians or those hospitals that the CT is not so accessible, let's say in a military way. I like this expression, but this is not feasible. And then it would be important to know the biological or biomarker alterations for these patients in order to detect the phenotype clinically. This is one issue. The second issue, because everybody asked me about that, is coagulation and anticoagulation. This is very important. I think is missed by radiologists sometimes. And if you don't perform angio-CTs, so it's difficult to suspect. So what is your advice for, well, you comment about this point, how we can include markers, biological markers or clinical issues in these phenotypes, and the second, anticoagulation.
Yes, very good, Antonio. Of course, I will not saying that, of course, everyone has to do the CT. This was started to try to describe what happens to the COVID-19 lung and to understand better the role of the different non-invasive mechanical ventilation in different patients. So then you can move also for other hospitals to lung ultrasound, however, essential. As lung ultrasound is very difficult to optimize treatment, and also lung echocardio. Echocardio is essential. We do echocardio in all patients. Regarding the vascular, we have a protocol, and we look mainly at the D-dimer, which is very important. And if the D-dimer is lower than 1,000, usually we start with enoxaparin prophylactic dosage at 4,000, 6,000. If the dimer is higher, so higher than 1,000, we always start again with enoxaparin at higher dosage. So for a 70 kilograms, 16 times 2. If the D-dimer start to increase more, and there is a peak in the increase, in that case, we always perform an angio-CT or echocardio, of course, to exclude thromboembolic pulmonism. If we have a macro on thrombi in transit, we start thrombolysis. We saved at least, actually, in our group, at least 6 patients in which we did the angiotac due to a deterioration, and the dimer was increasing, where we found a pulmonary embolism, even at on the 2 pulmonary artery, and they responded very, very, very well to the thrombolysis. If there is an increase in the D-dimer and we can exclude thromboembolism, and if there is microtep, we use enoxaparin at a little bit higher dosage than normal. And we move from this patient to warfarin, Coumadin, warfarin, after this. So we try to, I think that, I don't know if this is correct or not, but I think that it's very important to have clear guidelines on the coagulation process. Okay. And then we are looking at the BAL, different biomarkers, and also we measure Farkas, like this, everything, but we have not the data yet. So is the collection.
And don't you think, according to the Chinese, I reviewed many papers this year for journals, that what I have seen is that those patients that evolve to phenotype 3, there is a decrease in lymphocytes, an increase in the neutrophil lymphocyte ratio, and a decrease in the CD8. I think this is very important because it's very easy. Important.
But we have in our patient, the lymphopenia is in 2/3 of the patients. So of course we can have a look at the movement of the lymphopenia. But we found that, for example, different from Chinese, the troponin, even if we have pericardial perfusion, the troponin is never increased. So there are other probably biomarkers for the heart. You can get some sort of a SOVRA line in the ACZs as ST even after extubation. So the troponin was not, and the lymphopenia we have, but it is not in all patients. I can tell you that we are using also cortisone. So
this is a good point.
We use cortisone, methylprednisolone, and when we have the drug, because this depends on infectious disease, we associate cortisone with the tocilizumab, the anti-rheumatoid drug.
Yeah, my last question.
Corticosteroid, we are now studying the inflammatory response and very specific markers of the cortisone. And I have no data yet because these samples are given to another laboratory in the Gaslini Children's Hospital, actually. So we are giving this sample. We are very informed for immunology. But I can tell you that we had, of course, not all patients, because now we will try to characterize, but we have at least 1/3 of the patients when we gave the corticosteroid, they dramatically improved. So, of course, this is not randomized, but we are using corticosteroids at this dosage.
Can I just bring Professor Chu in here from China, just maybe to get some perspective from there?
May I add one very quick thing, Mark?
Very quick, yeah.
That was excellent presentation, Paolo and Antonio, but I found what you say very physiologically challenging and nice, but in real life, it is a real world. So I think that what you are showing, Paolo, is something related to 5% of the patients admitted to the hospital. Because out of 1,200 beds, we have 1,000 COVID and 100 ICU or intermediate care bed. All the others are outside. So I strongly believe that your phenotype are correctly taken, but the problem is we need to give suggestion to the large majority of people outside, those on spontaneous breathing. So we need to get some easy recipe to all the other people, because we are, let's call, expert, because we are either intensivists or pulmonologists or infectious disease, but most of these patients in the hospital are treated by neurologists, gastroenterologists, whatever.
Professor Chu, would you like to comment?
Yeah, for the corticosteroid, in China, for the very sick patient was severe or critical case, most physicians would like to use corticosteroid. When the patient's PF ratio goes down, or the CT scan or chest X-ray shows pulmonary infiltration get bad, and sometimes patients have the inflammatory response, high inflammatory response. So most severe or critical patient case in China received the corticosteroid therapy. The dose is prednisolone 2 or 4 microgram per kilogram for 3 or 5 days. But we have a cohort study that is show the corticosteroid did not improve the patient's outcome. Only in a phenotype, if the patients at the admission to the ICU, when the patient was admitted in ICU, if the patient has hyperinflammation phenotype, that to say in the high IL-6 or high CRP, or the patient's condition get worse very quick, that kind of patient's mortality could be decreased when the steroid was used. Other phenotype of the patients, the steroid could be increased mortality. Yeah.
Right. I think we need to move on in the interests of time, and really to go exactly where Stefano was just trying to go, which is the whole role of non-invasive ventilation and what we do to prevent a proportion of people, if that is possible, getting to this. And I was very struck by what Nick said early on, that patients having CPAP for 5 days, then deteriorating, etc. Whether 5 days is too long to be continuing with that, whether we need to be going in earlier to protect, to stop patient-induced lung injury. Stefano, would you like to just sort of start off the discussion on this as you were about to continue with that?
Yeah, as I told you, we have no recipe at all. At the beginning, we were thinking that CPAP was enough to, at least in the majority of patients, to improve oxygenation and the outcome. But then at the end of the day, Paolo is totally right. I mean, if they respond, they respond. If they don't, it is totally useless to keep going. And then you may introduce the phenotype 3 that Paolo showed. Yes.
Can I just, a really important question. When you say respond or not respond, what time period are you kind of thinking around that? Because that's obviously really critical.
I would say around 6 hours, more or less, to see if they can improve or not. But I found that in this patient, I don't know if Paolo, for example, agreed with me, and Antonio, we now prefer to put on basic oxygen. And basic oxygen time is better than CPAP. You got the same PF ratio, more or less, and I guess you damage probably a little bit less, I'm not sure. And we found that in patients, because we perform CT scan to all the patients arrive to the hospital. So we already have a CT scan in spontaneous breathing. If they have a posterior involvement of the lung, what we do, even in oxygen, we try to briefly to pronate, but don't think about pronation in intubated patient. We just ask the patient to prone. And I was told this morning, because obviously I cannot go to the hospital, that one lady came in tonight with 75 PF ratio, and as soon as they pronate her in oxygen with Venturi mask, or I don't know exactly which device they use, PF went up to 180, so it was impressive. So we learn every day. And another suggestion that I can make is that eventually in the patient showing patchy ground glass, we found a dramatic response to steroid. This is typical empirical observation.
Can we come back to the whole issue of the CPAP? So first question to everybody is CPAP, yes or no? And if CPAP, yes, how long for?
CPAP, no, mostly, and we prefer oxygen.
Okay. Would others agree from China, Dr. Chu and Dr. Pan?
We prefer use the CPAP or high flow cannula, nasal cannula first, and then NIV. But I wanted to show my slides. Yeah, this is the triage for the patient with COVID-19. Is mild, is no pneumonia, moderate is pneumonia but no respiratory failure, severe is mild ARDS. And the critical type is respiratory failure, need mechanical ventilation, either non-invasive or invasive mechanical ventilation, or shock or the organ failure require ICU care. But this is the paper published in ICM. It shows most of the patient died because respiratory failure. And others is respiratory failure or plus the myocardial damage. This is all data, is unpublished data. This is only at the beginning of the COVID-19. In Wuhan, the 150 patients died, fatal patient. Unfortunately, you could see the most patients received the nasal or face mask oxygen only, or the high flow nasal oxygen or the NIV, and only 20% received invasive ventilation before the patient died. So that to say, in China at the beginning, most of the patients did not receive intubation, did not receive intubation, did not receive mechanical ventilation. At the beginning of January, the expert panel commended all the medical team to evaluate the patient more carefully and to evaluate the respiratory efforts more careful and recommend intubation earlier. For example, if the patient first charge the patients develop to severe or critical care, this is SpO2. Also, the SpO2 higher than 93%, but the respiratory rate higher than 30%. Or the SpO2 less than 93%, but the patient, when the patients get off the bed, or the agitation, or also if when the SpO2 less than 93%, but the heart rate also is low, not very, there is no tachycardia, or the patient has a lethargy. So, and also there's other biomarker, as mentioned, some ex-professors before, is troponin, myoglobin, and CRP, interleukin-6, and also the leukopenia. And this is very typical the CT scan. I have a little bit different idea with Dr. Pelosi. Most of the patients, the CT scan like this. The top three picture is before the intubation. At the bottom, the three picture is after intubation, or maybe 3 or 4 days. That also shows that the bilateral infiltration and most not in the central, but not ground glass patch opacity is not at the center, but in the surrounding. And also, we noticed that many patients first receive the high flow or receive the NIV. In China, in Wuhan, at the beginning of the pandemic, there's not enough ventilator and not enough physician to do the intubation. So like this patient, fever 5 days, respiratory distress 2 days, and receive the NIV. But this machine, NIV machine, is just for OSAS, so we don't know the FL2 exactly. But the high pressure, low pressure is that, and the SpO2 is 90%. But when the patient transferred to the week 60, this NIV mechanical ventilator, we use the ST mode. We noticed that the respiratory rate very high and the tidal volume 100 milliliter. this is not an NIV, but we know many patients with there's huge inspiratory efforts. So in my opinion, is for the many patients, maybe the oxygenation, SpO2 is okay. Sometimes if the SpO2 less than 93 with a high FL2, okay, we agree, intubate. But many patients, the SpO2 is okay, but tide volume is very high and all huge inspiratory efforts or respiratory rate very high. At this time, we suggested that patient should be intubated. So we know the WHO guideline recommends the NIV or high flow did not longer than 2 hours. But in China, many patients receive the NIV or receive the high flow nasal cannula more than 5 days or 7 days. So we do believe that the longer NIV or longer high flow maybe is harmful. Yeah, this is my opinion. Yeah.
Okay, so we have a trial of NIV for 2 hours. What constitutes a successful trial of NIV, and what or of CPAP, and what constitutes a failed trial of NIV or CPAP?
If the patient receives the high flow or receives the NIV, we just evaluate the patient's SpO2 and also the for the patient's heart rate. Most patients' heart rate, there's no tachycardia, heart rate less than 100 or 90. Mostly we observe not only observe the SpO2 and also the respiratory rate and also observe the inspiratory efforts.
What is concerning me a little is that it's very clear that if somebody is getting worse, that's a very easy decision to make.
Yeah.
However, if they are stable or a little bit better, given all the other things that we've heard, and particularly, perhaps Nick Hart, you could come in on this, where you say people have been going on 5 days for CPAP. I can see a situation where people are just good enough not to need immediate intubation. But on the other hand, during that period of time, they may be inducing further lung injury, so that by the time they are intubated, we then have phenotype 3 that could have been prevented by earlier intervention. And Nick, would you like to comment on that?
Yeah, Mark, I think that has been our observation and our thoughts around this. And seeing that data there, when you're saying in Wuhan, that you had the situation that if somebody had a high tidal volume of 9 to 10 mils per kilo and a high respiratory rate, they were doing themselves more harm than we were doing good. And I think there's a balance here, a significant balance of making sure we are not propagating lung injury by these very inflamed, very soggy lungs being stretched with huge recoil that's going on in terms of somebody self-ventilating. And I think that has been necessarily our experience. These folk that are just panting away, that you may get them around and put some CPAP, but it's still a problem. And hence why we've opted for early intubation.
Okay, thank you. That's really helpful. Because I guess that what I'm hearing a lot of the time is that maybe we shouldn't be doing CPAP, and yet I think it was either Paolo or Stefano said the large numbers of patients who are on CPAP in the hospital at the moment. Now, I appreciate that some of this is driven by the reality of the situation, but perhaps Paolo or Stefano, to come back on this, do you think all those patients on CPAP in your Italian hospitals should be on CPAP? And in an ideal world, should they actually be either on oxygen or being intubated and ventilated? Because I think this is a really important point. If we're going to give CPAP, if we're going to give NIV, how long do we give it for? What do we regard as success? I guess failure is somewhat easier, but this sort of half and half house where they're a little bit better, but as Nick says, they're still doing themselves this significant harm, is something that we need to be avoiding.
I can just tell you what's our practical experience right now. I fully agree that our first choice is not CPAP. We started just with oxygen. So we start to give CPAP only if saturation is going below 95, 93, and with oxygen. at oxygen at 50-60% by Venturi. At this point, we try a test with helmet CPAP with 60% oxygen at PEEP 10. If the patients in the next, usually the patients that are going to improve, they improve within 6 hours, maximum 10 hours. So we do a test, and if the patients with CPAP, they have a saturation oxygen higher than 95, and the respiratory rate below, we say 28, but I mean something like that. So not to. In that case, we continue helmet CPAP. If the patient deteriorates with helmet CPAP, so that is going down below 95, and or respiratory rate is above 28, we intubate. But we have to divide, I think, 3 different categories. Those patients who are deteriorating, and at this point we intubate. Those patients that continue anyway helmet CPAP, but as a palliative care, which I think is very important, so that in this patient we decide anyway not to intubate, and so in this case we continue CPAP, but mainly for, and we associate diazepam and morphine. Actually, and those patients in which we have to continue, even if we would not like to do that, helmet CPAP, because we are organizing for a bed in the ICU. But I can tell you that, of course, this depends on the different organization of this.
Sure.
With Stefano, we also prone that some patients we put in the position during non-invasive ventilation.
Okay.
Paolo, may I challenge you with a simple question? You keep saying we. What do you mean we? Because this is a problem.
We mean that we are organized like this, that we have the intensive care are under all our control. Then we have another group of anesthesiologists who are taking care of all the emergency, and we have then we have of the more acute patients. Then the patients for helmet usually are transferred or from the infectious disease, and we have this team going.
Can we come back to this a little bit later? Stefano, what's the point you're making?
The point I'm making is the following. What Paolo was talking, we reassess, we put people 10 and 60% of FR2, depends who is taking care of this patient. In Bergamo, they have presently 156 patients on CPAP outside a critical care beds. So this means that there is no way for pulmonology or critical care physician to take care of them. So my impression is we overuse CPAP for sure. My point is what I said before, answering to Nick, 6 hours is more than enough to understand. And this is a classical practical experience we had. Last week, we ran out of helmet because, there was an overpressure on the companies. So we totally went around and we realized that the patient we were thinking of ideal candidate for CPAP, they were doing also, as they did for CPAP, mainly with oxygen and eventually pronation. So I don't think that CPAP, except maybe a small percentage, is really the trick to buy time unless you respond very soon. And this is something different from what I said 2 weeks ago. But I think one good thing in human beings seem to change their minds according to the time frame, because things may change. So I switch my mind. I don't say against CPAP, but I don't see that CPAP as let's say, the solution or even the potential treatment for this patient. Only small person.
So what I am observing in the hospital and what I am seeing regarding that you presented is that why is the most, so CPAP is not easy for us, for many hospitals, to be performed in the regular wards with COVID. Then I think the most simple thing is oxygen first, high flow second, and then intubation. And I have the impression that the CPAP can excitate or to increase the inflammation of these patients. I think that we should avoid CPAP for most of them.
Okay, could we ask one or two of the others who've not said anything yet? Josh, Manuel, Julian, what do you think?
Mark, can I just make one small point? I've just gone through the data for our patients that have been invasive mechanically ventilated early. And of the patients that have come through and the survivors, and these are only small numbers, you know, we'll have to verify them, but our length of stay on the intensive care or intubated is 4 days, and the mean age is 54. Now, I agree, you know, we've only got, you know, and it's not too small, it's in double figures, but I just want to make the point, we've taken a role of early intubation, and we seem to be having people ventilated for less time. If I tell you about the non-survivors, they are actually intubated longer than the survivors, and in fact they are significantly older. And I think we've got a real signal. And Stefano, what you said 2 weeks ago, in fact we've taken on board not to roll out CPAP, but to think about early intubation.
We come back to this again in a moment. So if we could, thanks very much, Nick. So Josh, Manuel, Julian, is there anything you would like to say from your experience to add to this?
Yeah, I'm just getting started here, but I did have an interesting kind of construct that I think could potentially link together a lot of these things. Can I just show that real quick? Many of these patients seem to have this like malignant form of ascites, of atelectasis, where they kind of get really bad really quickly, they fall apart, and then, you know, it's possible that we can ventilate them and they may recruit and possibly get off the ventilator fairly quickly. So the question is, what is going on here pathophysiologically? And I think one player here may be, you know, typically alveoli kind of hold themselves open. I wonder if, you know, the alveoli are basically kind of getting like micro atelectasis, and then as the lung collapses, more and more of the lung collapses, and it kind of creates this cycle where, you know, the lung is becoming increasingly atelectatic, all of the lung architecture is lost, and so on and so forth. Patients are taking lower tidal volumes, and this creates kind of like a vicious spiral that explains how patients can go from being okay, and then like 12 hours later, they're just like completely disastrous. And I guess this could potentially lead to some kind of implications as far as the therapies that we're giving these patients. So I think there's probably some patients in this very early period where they have some atelectasis, they're doing okay. You could pronate them. Possibly you could put on CPAP. You could keep them from developing this really malignant atelectasis. And that could potentially be a big win. I wonder if we should be applying CPAP earlier before these patients really collapse and preventing them from getting into this spiral. Then I think there's certainly a group of patients who are rapidly spiraling down. You put CPAP on them and you can maybe prevent them from getting worse, but you're not going to get them better. And that's the patients that are going to have this self-injurious lung injury. And those patients may not do tremendously well with CPAP. Maybe those patients should be intubated. And the patients who do get intubated, I've had really good experience so far, and I've only seen a couple of patients with APRV as far as recruiting the lung. So I do wonder if these patients could benefit from more of like an open lung strategy.
Okay, thank you very much, Josh. Manuel or Julian, anything you would like to add? And then I'll try and summarize this before we move on to the next section.
Yes, for my part, things are not very clear-cut. At the beginning, we were told not to put a patient on an IV or CPAP due to concerns about contamination of medical staff, and due to the very rapid worsening of oxygenation. So the dogma at the beginning was to intubate patients as early as they were admitted to the intensive care unit. But we were obliged to revise this dogma because many patients were not so bad when entering the ICU, and we were very distressful to intubate them on the spot. So we try an IV with helmets on many patients now, because we have 190 patients in the ICU at Strasbourg University Hospital. So a large bunch of patients were on an IV, and we had two phenotypes. Half of patients got better, and they could be weaned from an IV and go to supplemental oxygen, and some patients got worse very, very quickly, and had to be on mechanical ventilation. And those patients who got worse under NIV and were to be intubated, they got really worse with very stiff lungs and low compliance and very difficult to ventilate. This is our short experience.
I think it's confirming similar to others. So just before I try to summarize, could we just go back to this topic of high flow nasal oxygen? Because in the last webinar, there was a general view that this doesn't work. And yet today I'm hearing a rather different story, that oxygen is the key. Tony, you said that you're using high flow. Where do we stand with regard to this?
Well, I think that, as I said before, using high flow is easier for those patients that cannot be admitted to the intensive care unit because the units are full. It's very difficult.
The key thing to me is, does it work?
At the beginning, yes.
Does it improve survivorship? Because this is what has been difficult for us when it's been used once or twice, and we haven't used it really at all.
Well, I don't know at this point.
Does it A, oxygenate patients better, or B, does it, for instance, bring respiratory rate down in a way that oxygen does not do, reduce tidal volume, in terms of just looking at the patient?
No,
reduce
yes.
Respiratory distress?
I think at least the patients feel more comfortable.
Okay. Stefano, last time you said that it didn't work. Have you changed your view?
Yes, we changed a little bit of our mind. When I said oxygen, I mean either high flow or Venturi or even reservoir. I don't think high flow nasal cannula adds much to reservoir bag, for example, or Venturi, but still, in some patients, I agree with Tony. I cannot reply to Nick. Does it improve survival or not? We don't know.
I guess I don't think anybody's going to be able to answer that question. But for me, the key issue is the potential theoretical increased risk of droplet spread. And I appreciate that with well-fitting nasal cannulae, et cetera, this is low. Is it worth, and the expense and the fact of all the other issues that we need to consider, does it add sufficient above high flow oxygen through just an ordinary reservoir bag, a face mask without a venturi, to justify doing it? Because I think that's the key question. And what I would be looking for is either people that you could now oxygenate that you couldn't using the previous techniques, or that you saw a significant fall in respiratory rate and respiratory distress that you could then argue would prevent that patient progressing to the point of patient-induced lung injury, et cetera, that we've been discussing earlier.
The second point, I agree with the second point. If the respiratory rate decreases a little bit, the patient is more comfortable, there is less fatigue, and that's important.
Okay. So look, just to try and summarize what I think we're saying, and please disagree with this if I'm getting this wrong, is that in the early stages, well, I suppose just before saying that, the first thing to say is that the likelihood would be that there is a spectrum of disease here, given that the vast majority of people never come anywhere near hospital and have mild disease. So one would expect from first principles that there would be a proportion of patients who should be able to be managed using non-invasive techniques. That's what one would expect. And I suppose that the key thing is identifying those patients, and that when they are clearly not benefiting, or that we stop it and we change strategy. And I think the thing that concerns me is the potential for that halfway house where they're not getting worse, but they're bad enough that they're still doing themselves damage. And that group of patients is going to fall into two categories. One, for whom CPAP, non-invasive techniques, are the ceiling of care. And then there is a question of how long it is fair to continue to subject the patient to that if there is not a reasonable chance of them surviving, and also how long is it reasonable to continue to subject the nursing and medical staff to the risk of infection. And then the other group is the group where it's to escalate to invasive ventilation. And what I'm hearing people saying is that a 6-hour trial of CPAP is enough, or nasal high flow, whatever, is enough to make a decision as to which way this patient is going. If they're deteriorating, it's very easy. You intubate them or you palliate them. If they are significantly better, and that is to be defined what exactly is significantly better, then it is reasonable to continue with CPAP, high flow, whatever you have chosen to use. But if they fall into that middle category where they are holding their own, so they're not getting worse, but they're not getting better, how long do people think it is reasonable to continue with CPAP? Should we just say at 6 hours, right, this patient hasn't got better, we should intubate them? Or do we give it another 6 hours, another 12 hours? What do people think?
I want to share with you the protocol we have in the hospital. Okay, this is our criteria for starting CPAP or NIV. We start with CPAP NIV to differentiate the responders or non-responders. And the duration of this test is really around 2 to 6 hours. If the patient responds early to the CPAP, we continue the CPAP or NIV in a pulmonary ward monitoring unit. If the patient is considered non-ICU admission, as Nick said before, we start CPAP with a PEEP of 12, more or less, as a saline of therapy. The second question is the withdrawing protocol. If the patient has good tolerance, we continue with CPAP or NIV during 48 hours. We start with intravenous fluid, and after this 48 hours, if the patient has SpO2 more than 92% on CPAP and the respiratory rate decrease below 30, we have called this protocol the OP protocol, oxygen, PEEP, and intermittent NIV. This means that we decrease, first of all, the oxygen FiO2, and the second stage, we decrease the PEEP, and the third stage, we provide to the patient intermittent NIV, and we assess these changes 1 or twice per day. For example, if the patient, if we can decrease the oxygen, we stop CPAP or NIV only for the meals. If IO2 is less than 40%, we decrease PEEP with the objective to achieving a PEEP less than, equal or less than 8 centimeters of water. After, if we achieve this goal, we provide intermittent CPAP 2 hours during the morning, 2 hours during the afternoon, and during the night. And these are the criteria for withdrawing the CPAP. If the patient, after this point, if we don't achieve the goals, we evaluate early enteral feeding and decide to continue CPAP or NIV, reassessing this protocol every 24 hours. This is relatively new. We don't have at this time results, but our feeling is that when the patient responds good, very good to CPAP, we can maintain the CPAP for 2 or 3 days, applying this withdrawing protocol.
To wind back one step, I would still like to ask the question of everybody: would we regard an oxygen saturation of greater than 92% and a respiratory rate of less than 30 as being an acceptable response to CPAP? I absolutely understand that it's acceptable in the sense that the patient doesn't need intubating, but is it acceptable to leave somebody like that for 3, 4, 5 days, bearing in mind what we've heard from Nick, Paolo, Professor Chu, etc., etc.?
My view is, Mark, not. And I think it's all dependent on how the patient is responding, not just with their respiratory rate, which is obviously a blunt marker, because you can have people with low respiratory rates and a very high tidal volume when you're looking at them, as in when you look at their chest movement. So again, we need to get to the concept of patient-induced lung injury being the primary difference between our usual approach to patients who have a pneumonia or viral pneumonia. And I think you are right, this is a very different condition. Can I just make a comment about high flow that everybody on the webinar will be aware of? That high flow adds a huge oxygen debt to the hospital system. And we know in our hospital system that the manifold can produce 3,000 litres of oxygen per minute. That's 300 patients on 10 litres per minute. If we move to 50, 60 litres a minute, we will not be able to support that. And part of the reason high flow, apart from around efficacy, which we've heard today, I think my problem is about the oxygen debt to the system which you're working in that is a major problem. There may be infective contamination issues as well, but they're less of a concern to me if we have PPE that is effective.
Okay, thank you very much, Nick. It's an important point. We're having to think in terms of things we don't usually have to think about. But just one other thing I would like to just mention is the question of the helmet, because I think the reality is that for a lot of us, the helmet is not even an option because we just can't get hold of them. And I'd be interested to know whether in Spain and France, you're still able to get helmets, and if not, what you're doing and how much success you're having with oronasal face masks. So Tony, I know you want to say something else as well. Do you want to say that and then perhaps comment on that?
No, we do not have helmets, or if we want to get them, it's very difficult.
So what are you doing with CPAP or NIV? Are you using full face mask, oronasal mask? You're not doing much?
Not much.
Okay.
We are using a lot of high flow or a high concentration oxygen with the back.
Sorry, just one other point I've just remembered I wanted to make, that what Nick just said is very much in keeping with what Rongchang Cheng said last week, 2 weeks ago, that severe dyspnea of itself, they regarded as an indication for stepping up to invasive ventilation, if I remember correctly. And that would really fit with this idea of people with either a very high respiratory rate or a very high tidal volume, etc. So I think that is probably another important point. What about when we are using CPAP? What CPAP pressures are people recommending? What's the starting pressure? What's the protocol for escalating it? Starting at 10, going up to 15, going up to 20. What are people doing? Stefano, perhaps you've used CPAP more than most.
Yeah, we were using a lot the helmet, as I said before. So we started at 10, definitely, and most of the doctors were not trained at all. So we need to train them to go up eventually only based on saturation. We fix the number on 93.
Yeah.
Just without any evidence, but just to give a number to neurologists, for example, to set the helmet. The other problem of the helmet is that unless you have a venturimeter, you consume also a lot of oxygen. Yeah. It's not as much probably as high flow, but as Nick pointed out before, you should be very careful in which helmet and system are you using to perform CPAP. Otherwise, you will easily get...
Stefano, this is not an issue for us because we can't get hold of helmets. So it's not going to be... You're using them all. Dr. Pan in China, yeah. Dr. Pan, you wanted to say something.
The first thing for the NIV, we use a lot of NIV and high flow. We do not have the helmet, so we cannot use helmet here.
And you're using it through what? An oronasal mask, face mask.
Mask. Yeah. And for the setting of the NIV and the PEEP, we set around 8. At most is 10 centimeter water, and because if the PEEP is higher, the patient cannot tolerate. And if the patient is getting worse, the criteria for me to decide to intubate the patient, the first one is the severity of the patients. A second is the PF ratio, if the PF ratio less than 150. The third one is the patient have very strong spontaneous breathing. This is the criteria for the NIV. And for the high flow, and for the NIV, another point is that the very high tidal volume. As we said, if the tidal volume is very high, higher than 9 milliliter per kilogram PB wet, and maybe I will think about if the tidal volume is higher than 12, maybe the patient we should intubate to not care about the SpO2. And for the high flow, for the criteria, because we cannot measure the tidal volume, so we use the ROX index. ROX index is we use SpO2 divided the FiO2 and the respiratory rate. If the ROX index lower than 2.8, it means the patient has a very strong spontaneous breathing and very low SpO2, and maybe we intubated the patient. If the ROX index are between 3.8 to 4.8, it seems we can wait, but we should to monitor the patient very closely. maybe 2 hours or 3 hours. And if it's getting better, okay, we can monitor it, go up. If getting worse, maybe intubate this patient. If higher than 4.8 to 6, maybe the patient, we can wait 6 hours or 12 hours. Yeah, this is our criteria.
Manuel, you said that you would like to say something about the use of home ventilators, etc.
Yes, I've tested some home ventilators in the laboratory, and there are some ventilators that can be used as a CPAP in the acute care setting. But there are some home devices that are not able to provide enough support to this kind of patients. If I can share my screen. This is an example of 2 devices tested in the laboratory. You can see both devices are in CPAP mode with a PEEP of 8. And you can see that the first device, the pressure, this is the blue waveform, the pressure during inspiration, the simulator was programmed with a huge effort, that you can see that they decrease during inspiration. In the first tracing, it's much more pronounced than in the second. So the message would be not all the devices, home devices, are able to provide enough support due to the features of the turbine to provide enough support in the acute care setting. This is my conclusion.
One of the things that I've been looking at is that the flow rates that different devices, not in a bench model, but asking the manufacturers the flow rates of the different machines. Do you think that's adequate?
Yes, the flow, it seems adequate, and if the flow is not adequate...
Can you give a number to what you think is an adequate flow?
Adequate flow, a peak flow higher than 80 liters per minute would be adequate with a huge effort of the patient. For example, I programmed in this simulator, in this bench model, an effort of 22 centimeters of water. That is a huge effort. And you can see here that the decrease in pressure during inspiration is much more higher in this case than in the second.
Flow on the left. Do you know what flow rate that could generate as a maximum?
Yes, this is 60 liters per minute at 80 liters per minute with the peak flow. This is 60 and this is 80.
That's the patient's peak flow, yeah.
Yes, that's the patient's peak flow. In fact,
that's the key. You couldn't keep up with that peak flow. That's the key.
Yeah, that's the key. The key is the ability of the turbine to provide enough flow during inspiration. If the patient feels uncomfortable, we usually shift to pressure support with low values of pressure support, monitoring always the tidal volume. We monitor a tidal volume, and if the patient is doing a tidal volume less than 4 or 5 milliliters per kilo, we change to pressure support. If, as Professor from China said, if the patient on CPAP is doing a huge effort and the tidal volume is around more than 8 or 9 milliliters per kilo, we decide to intubate the patient.
What we want to just focus on is the use of a home ventilator. So most home ventilators, domiciliary ventilators, will not give you a tidal volume. I'm thinking of the situation where you have 200 patients needing endotracheal intubation and you have 150 ventilators, but you have a whole load of home ventilators or other machines. Last webinar, Stefano NAVA said they were using anything they could get their hands on, even a can of tuna. He didn't explain how a can of tuna would ventilate a patient. But will has anybody had any experience of using home ventilators, so home CPAP machines for patients with sleep apnea, home ventilators used for patients with obesity, hypoventilation, COPD, neuromuscular disease, to be using these for invasively ventilated patients or for providing CPAP? Manuel, have you had any experience of doing that, or no?
No, not in invasive ventilations. I've classified the ventilators based on the ability to provide enough
You
flow.
haven't had experience of it in vivo, in a real.
Not in invasive ventilations. The only experience we have with invasive ventilations is during the weaning process.
Okay, well, I was going to come to that in a moment. Okay, so what about anybody else? Paolo, you've got however many hundreds of people on CPAP in your hospital. How are you delivering the CPAP?
We deliver by CPAP with Venturi, with helmet Venturi. And then we use positive pressure at extubation, but this is we do in the ICU.
So through the helmet, it's driven by oxygen from the wall.
Oxygen from the wall.
Okay, so nobody's been using home machines in any way, shape or form for these critically ill patients.
So Mark, the issue will be this is a hypoxic, severe hypoxic lung disease. If we entrain oxygen into a home system, you'll only get to an FiO2 of 0.4. You know, these patients are seriously requiring oxygen. And so it won't be beneficial to do that. And I think we need to send a message out, and we need to consider that message that using a home-based system and just entraining oxygen with the mixing of air and oxygen, you just won't get an FiO2.
You won't if you've got a big leak in the system, but if you're ventilating somebody through a tube, you may be able to get significantly higher FiO2 because you won't have so much leak. I mean, I think basically we should move on. I think it's an area that needs to be explored further, because there are people working on ways of trying to increase the FiO2, et cetera, et cetera, et cetera. Tracheostomy, early tracheostomy, with the potential of switching somebody to a home ventilator. What do people think about that? Is that a reasonable thing to consider? So in other words, you've stabilized them in the early phases with a high-end ICU ventilator, then they're now getting better. They're not in a position where they can be removed from ventilation, but one might not need such a high-spec ventilator for some patients. Is that a possibility?
I think that this is a good point. And I think that this is going to improve or to speed the weaning process and to ventilate the patients with the non-sophisticated ventilator. So something to be really considered. The only problem is that is a surgical, or let's say almost surgical procedure that complicates the management of the patient. And some of these patients are with anticoagulation, as Paolo said, and this is something to be considered.
Issues because it also potentially frees up a high-end ICU bed as well, because the patient could be managed in a lower intensity setting. Paolo Pelosi, you have something to say.
Actually, we are going to have a patient more in assisted ventilation as early as possible, and the problem is that the weaning process from PEEP. So what I mean is between 12 to 7 is very long. It takes at least 1 week in our experience. So what we do now is that we started to do tracheostomy after 2 weeks, and we do surgical because the percutaneous needs that you have to use the fibroscopy, and we thought that this is too risky actually, so we did surgical tracheostomy. And of course, we have not customized many patients, but we have the impression that this can be also to be considered. So we started to use also tracheostomy after 10 days, 14 days.
Okay.
So Mark, can I just add, because our ear, nose and throat surgeons are less occupied currently than they were previously. We haven't started, but what we have with our ENT surgeons, they're actually going to do percutaneous tracheostomies for us. And the reason we want to engage with our ENT surgeons to do percutaneous is obviously the aerosol generation. If you do a surgical tracheostomy, that when you're going to contaminate, and when you're talking about AGP, aerosol generating production, that was a real concern to us. So that's the approach we are going to take.
Okay, thank you. What about this whole process of weaning? Are people using non-invasive ventilation, CPAP or high flow as part of the weaning process?
We use non-invasive ventilation according to our protocol, but we use high flow as well, both.
Okay. How are others doing it?
We use the just as you said, the tracheostomy, because we do not the tracheostomy very active, because when the patient getting better and we do the tracheostomy, because I have 2 patients do the tracheostomy and we do the prone position, and the patient have the tracheal bleeding. It's a disaster. So for the patient, when the patient getting better, and we do the tracheostomy. And then after the tracheostomy, we give the patient to use the high flow connect to the ventilator, and we use the high flow. And at the expiratory port, we connect to a filter to avoid the pollution of the air. The air. Yeah.
Okay.
I have one question.
Professor Chu has a comment.
For most severe ARDS patient with using invasive mechanical ventilation, most patients need the deep sedation, and most patients need neuromuscular blocker. So when the patient's ARDS get better, we decrease the PEEP and spontaneous recovery, give the patients at that time, almost the patient take a long time for mechanical ventilation. So if the patient getting better, if the mechanical ventilation longer than 2 weeks, just mentioned by Professor Paulo, most patient, we do the percutaneous tracheostomy because the weaning process is very long for this kind of patient.
So about 2 weeks.
Yeah.
Okay.
I have a question for all of you. Do some of you have data about contamination and viral spread using high flow nasal cannula? Because we all use it. It seems that we all use it, but do we have safety data to assume that we do not contaminate healthcare practitioners?
For the use of high flow nasal cannula, there are several studies looking at environmental spread. I have done it through a human patient simulator using smoke particles 1 micron in size, and using a laser beam to light up the particles so that we can see the quantity of the exhaled air, and then analyzed by a computer. So basically, if you clip on the cannula properly, the exhaled air is just vertical from the nasal cannula upward above the patient. And the distance is about 172 mm if you connect the cannula properly. But if there is a loose connection at the edge, then you will see a sideways jet of about 620 mm laterally. Yeah. So this is the only problem when you use the high flow nasal cannula. Now, however, this is only based on human patient simulator and smoke particle. Now, and then there's another group in Japan. They were also using the human patient simulator, but they use some starch powder as the marker, and they also found very similar exhale air distance up to about 600 mm above the patient around the face. Yeah. So again, this is only based on human patient simulator.
Okay.
Yeah. Another study by Dr. Serena Leung, my former colleague in the intensive care, she was studying patients with gram-negative bacteria in the intensive care units with air changes between 6 to 12 per hour. And she put culture plates around the patients and then tried to count the number of colonies grown on the culture plates. And she compared high flow nasal cannula against oxygen mask. And basically, she could hardly find any colony growing the bacteria. And her conclusion was that the high flow nasal cannula did not produce extra infection risk compared to the oxygen mask, and implying that if you comply with contact and droplet precaution, That should be sufficient. And then I have found another 2 studies. There's one from Singapore, published in the Canadian Journal of Anesthesia. So there were 5 anesthetists. They were using some red and blue food dye to gargle, and then they try to cough. And they measure the cough distance as somewhere like 2.48 meters, which is amazing, you know, because normally the droplet distance is only 1.8, right? So WHO adopt 1 to 2 meters as the safety distance. But somehow these five guys, they must be extra strong, you know, in the lungs. So they were able to cough up to 2.48 meters. And then they put on the high flow nasal cannula and cough again. And the distance increased to 4.5 meters. But I have some query with the data because number one, they were using food dye, you know, as the marker. And I don't know how they could produce 2.48 just by coughing without the high flow nasal cannula. You know, normally your lung cannot produce such a far distance. So CDC and WHO use 1 to 2 meters as the droplet safety distance, right? And then there's another abstract actually published by Fisher and Paykel in collaboration with 2 universities in New Zealand. Again, they were coughing and they were using some instrument to estimate the cough distance, and it was up to 4.4 meters. Now, it was only a conference abstract. There was no detail about the methodology, so I can't really comment. So I guess at this stage, if you have to use high flow nasal cannula for treating COVID-19, complicated by type 1 respiratory failure, well, I think you probably should use a surgical mask to cover the high flow nasal cannula, just in case the patient coughs during use of the high flow nasal cannula. And at the moment, the WHO actually has a working group trying to perform experiments using real patients infected with COVID-19 in the isolation room, and we would put viral samplers around the patient and try to look at the PCR and also viral culture. The problem with this sort of experiment is that you have to do it in the negative pressure isolation room with 12 air changes per hour. And the room is so efficient that I think you remove all the exhale air very quickly before you can see anything. So I bet it is going to be a very expensive negative study.
Okay. So David, just to summarize, so as long as you've got the circuit all fitted together okay, and if you wear a mask, the patient wears a mask, particularly if they're coughing, the risk to healthcare professionals should be extremely low.
Yeah, I think so. Because the major concern now is during use of the high flow nasal cannula, your patient may cough, and the cough velocity can be very high, you know. Okay. So if you can use a surgical mask to cover the cannula, I think that would actually reduce the chance of nosocomial transmission.
Okay, well, that's a really helpful tip. And I guess if the connector is loose, you'll get flow, you'll get gas flow, but will that flow be contaminated because it won't yet have reached the patient?
Well, it depends on whether the patient is coughing at the same time. Okay. If the connection is loose, then you will have a sideway jet laterally. So,
okay, so if the patient then coughs into that, it'll send it further.
Yeah.
Okay.
Yeah.
Okay, right, that's really helpful. Also, there's a lot of discussion around CPAP, and in Italy, certainly the preferred interface has been the helmet, but talking to colleagues around Europe, a lot of people are having difficulty sourcing helmets, and I think most of them are in use in Italy. And so we're looking at non-vented masks with a viral filter. Do you have any comments about that?
Well, I think if you can actually use a non-vented mask with a viral filter, which is presumably single circuit, right?
Yes.
I think that would actually help reducing the risk of nosocomial transmission. Other masks that you may consider is the Quadro oral nasal. Previously, when I performed experiment on the Quadro mask, I could actually see a very diffuse exhale air coming out in very low concentration. In contrast to the old generation masks produced in about 10 years ago, you know, those old masks actually had a very turbulent jet. It was very efficient in removing CO2. But if you use it in the infectious disease setting, you could contaminate the room, even in a negative pressure room, very easily, especially when you increase the IPAP. So if you have no choice but to use oral nasal mask maybe consider using the quadrupole.
Or is it just a feature of any of the modern masks?
Yeah, I think in recent years, most of the manufacturers, they recognized the problem with the older generation mask, which was very bad in the exhalation port design. So I think they actually have improved the design. Most of the brands actually have now very good exhalation port.
Okay, so the key thing is to use a modern mask, non-vented mask with a modern exhalation port.
Yeah.
Okay, and then just a couple of other brief comments or questions for you. In the first webinar, I was very struck by a difference in healthcare infection rates between people working in Guangzhou and those working in Wuhan. I think it was 3,000 healthcare workers infected in Wuhan, whereas in Guangzhou there were none. Any comment about that?
Well, basically, Wuhan was at the epicenter of the COVID-19 outbreak. They were taken by surprise. They were not well prepared. So in fact, if you look at the statistics, more than 50% of the cases in the mainland of China actually had occurred in Wuhan. So the healthcare system was overwhelmed. The ward was very contaminated and overcrowded. So as a result, they had more nosocomial transmission. The infection was actually spread to other provinces just before they shut down Wuhan. You know, they announced that they would shut down Wuhan at 10 a.m. on the 23rd of January. But 5 million people actually escaped. They heard about this curfew. So they actually went to different provinces. And Professor Zhang told me about 0.3 million people actually went to Guangzhou. But they were actually better prepared because they saw the epidemic, the outbreak spreading. And also the number of cases treated in Guangzhou is a lot lower compared to those in Wuhan. So I think they are coping well because they don't have a huge number of cases, and they were also better prepared.
Okay, and what do you think the key elements of that preparation are? Patient segregation, of PPE, disinfecting procedures?
I think the experience in handling SARS in 2003 was a major benefit to my colleagues working in Guangzhou. Yeah, you know, SARS actually originated from Guangdong in 2002 in November. They had handled a lot of atypical pneumonia, and they actually experienced outbreak of SARS, and they actually had a lot of experience using NIV and also other respiratory support. So experience and also the reasonable caseload, not overcrowded wards. I think all this contribute to better results.
And then just one last question that may only be of any relevance to the UK, where we historically have not worn, medical staff don't wear scrubs, but wear our normal everyday clothes. And the concerns are being raised about this and people taking the virus home. Do you have any comment on that?
Well, we certainly would recommend, if you have to handle patients with suspected or confirmed COVID-19, you need to wear surgical mask if you are not performing aerosol generating procedures. You need to wear an eye shield, put on gowns and also gloves. And also make sure you degown properly. My colleagues in Wuhan told me that at one stage, they had a lot of nosocomial transmission, not related to respiratory therapy. And they were actually quite tired after working for a number of hours, and they did not degown properly. And as a result, when they attended case meeting in the tea room, there was actually outbreak of nosocomial transmission. So their clothes were contaminated. Yeah. So I think we have to dress up and also degown properly, and also pay attention to your shoes. There is some experience from the colleagues in Singapore. They actually perform an environmental studies. The patient actually had the respiratory sample quite high in viral load. The CT value was 26 units on about day 4 or 5 of the illness. And then they actually performed environmental samplings in the room before cleaning. And they found PCR positive in the shoes on the surface, although the CT value was only 39, quite low in concentration, but they did find the PCR. And there was also the contamination of the room, floor, bed rail, even air outlet, chairs, and stethoscope. So we have to be very careful with environmental contamination.
So hard surfaces are the particular risk?
Yeah, yeah. The virus can survive on plastic or steel surface for 2 to 3 days. Yeah.
Okay. And that would include the plastic aprons as well that we use.
Exactly. So we have to degang properly. Yeah.
Yeah. And then just finally, a number of years ago, I was involved in a study that we did looking at environmental contamination with bacteria. And we found that the biggest procedure that generated the most contamination was actually making of beds. Do you think this is an issue, that we have patients who are COVID positive in beds? Will the virus survive on the bed linen and the nurses making the beds? Is this an issue?
Well, if there is something that can absorb the moisture of the virus, it doesn't survive that long, you know. It is actually on plastic or steel surface, something that does not absorb the moisture, that the virus will actually survive much longer. But of course, now even with bed linen, you can still have some trace of the virus. So we have to be very careful in disposing the used bed linen.
Okay.
We aren't all using high flow.
Yeah.
In the UK, the guidance is not to use high flow.
Okay. Thank you very much for that. Right. Tony, I think that the bit about biomarkers and things you said earlier, is there anything else you want to say now?
Yes, please.
Okay.
So my impression, following and reviewing all the papers from China, from our own experience, is and I'm sorry because I have the data, but I couldn't organize in a slide form. We are writing a paper on that. So again, lymphopenia, I think is important. Those that go to the ICU decrease the lymphocytes within time. They decrease the CD8. The neutrophil lymphocyte ratio increases, and then a couple of important points or important biomarkers. D-dimer is increasing, one, and ferritin is increasing as well. And in several multivariate models that I read from the papers, the most feasible and related to the worst progression are the neutrophil lymphocyte ratio, which is very easy to use.
Okay, thank you. That's really helpful. Can we just spend a little bit of time talking about service organization when demand outstrips supply? I think this is a situation that colleagues from Italy, Spain, and probably you in France as well have experienced, and China, and Nick, I suspect you're in the same place. And it's something that is a big issue for people who are just beginning to see the beginning of this epidemic. So I think that Julian, you wanted to say something about this. Would you like to share your thoughts?
Yeah, thank you very much. So I will tell you some words about our experience in Strasbourg. We now have 190 ventilated COVID patients in the ICU, and I will tell some few words about the COVID pandemic in what we call the Grand East area in France. It all started out 1 month ago in a town which is called Mulhouse, at the south part of the area that we call Alsace. And very quickly, this cluster spread all around Alsace and Grand East area. And you see on this map that the initial cluster was at the south of Alsace, and very quickly the Mulhouse hospital was overwhelmed by COVID ICU patients, and the pandemic quickly spread to the north. And many patients from the Grand East area were infected. And on the next map, you see COVID positive patients ventilated in the ICU, and this photograph was taken just yesterday. So you see there are a major cluster in the eastern part of France and around Paris and in the north. So I will just tell some few words about Strasbourg University Hospital. It has two main buildings. and it has 2,134 beds. And on March 2, we had 100 physical ICU beds, but only 80 staffed and equipped ICU beds on both buildings. 3 weeks later, we are now with 205 physical ICU beds and 188 staffed and equipped ICU beds in both hospitals, which are very close from each other, around 5 kilometers. So here you can see the suburb of Strasbourg and the link between university and private hospitals in the Grand East area. And you see the isochrone borders, and this is the distance that you can make in 50 minutes and the distance that you can do by car in 1 hour. So very quickly, it appeared that we had to prepare, and so we were very happy to have some tools emerging from the ISIGM and from other scientific societies. This was very important for us because in very quickly we have to give healthcare professionals some clues how to wear personal protective equipment, how to wear gowns and helmets and masks. And we use very quick videos so that people that were not get used to wearing those clothes could get accustomed with them very quickly. And we had to prioritize activities, and many non-emergent surgery were unscheduled. So this provided availability of operating room staff and availability of post-anesthesia care units and also step-down units. So to prioritize surgical activities, we had to be very equitable between surgeons, and we used the NEST criteria, and we only kept emergency surgery which had to be performed within an hour. All other surgical cases were either cancelled or taken to another hospital in Strasbourg suburban area. So this provided us a large surgical task force with many non-ICU physicians, surgeons for instance. We were very eager to help, so they were taken in the ICU teams to prone patients, to complete medical charts, to give families information, and to participate in end-of-life decisions. To provide them with a very quick refresher course, we used online resources from the American Society of Critical Care Medicine and from the French Society of Anesthesia and Critical Care. We had to extend the boundaries of critical care in the hospital. This is, for instance, the surgical ICU, and we had to open some rooms that were closed 3 weeks ago. We also had to monitor the corrected QT interval in patients receiving antiviral therapies because we had some cases of torsade de pointe, and so we were very eager to monitor the QT interval. And so we also had to extend our boundaries in the step-down units that were equipped with high-end heavy respirators, and we had to teach very quickly healthcare practitioners how to cope with COVID-19. And we also had to equip our post-anesthesia care units using transport ventilators that were customized to deal with highly hypoxemic patients. We also were very keen on using ICU medical chart that was developed and spread in the post-anesthesia care unit. And this is, for instance, a small chart how to use a transport ventilator to ventilate an ARDS patients in the step-down units or in the PACU. But we also had to extend the boundaries outside the hospital. The first example is now a chart to cope with the transfer of ICU patients from Strasbourg and France to other countries, for instance, to Germany. I will show you some slides. This is a 13 ICU beds hospital that was completely built up in, let's say, 2 days, and which was army staffed and fully equipped and staffed with military healthcare professionals. And this was near the Mulhouse Hospital. We also required Morphe military ICU plane, which is able to fly with 6 ICU patients aboard. And this was used to transfer patients from Strasbourg to Paris, and also from many German hospitals. And the last vector we used was the high-speed train, and we were able to transfer 20 patients from Strasbourg to Nantes in a 7-hour journey. And all patients got well and were admitted in 2 different ICUs in Nantes, and this was very successful. The next 2 slides, here are some clues that we used to use new tools and to characterize the lung disease in COVID-19 patients. And this was developed using software developed by Professor Soler in Strasbourg, France. This is derived from the Visible Patient Project. And here you can see in this very obese patient, the kind of baby lung, and the ground, excuse me, the ground glass areas are shown in yellow on this presentation. Here is another patient that was operated on from esophagectomy, a Lewis-Santi procedure. And you see that the photograph is taken from the back, and that there is a large reduction in the right lung on the left side of the picture, and the right side, all the green areas are ground glass opacities linked to COVID-19. So thank you very, very much for your attention.
Okay, thank you. Manuel, you also had some comments about how to manage when demand exceeds supply. Thank you, Julian.
Yes, this is the organization of our in our work in our respiratory department. We have built a step-down unit, as Julian said. It's more or less the same, with 20 monitored beds. In these beds, we admit patients, high-risk patients under NIV, and it's a step-down unit also for discharge, for early discharge from ICU, for example, patients with early tracheostomy. In the other side of the world, we organize a unit with 22 non-monitored beds for CPAP therapy, but only for candidate with patients who are not candidates for ICU admissions. The procedure for building up the monitored beds is reflected in this slide. We have collected all the monitors all the monitors who are able to transmit data, and we through a Ethernet cable we build TV screen who are located in the nose control. This is really very useful, and in a weekend we were able to organize a monitoring unit in our respiratory ward. And this we are preparing now this huge space in an area under construction with a capacity for more than 100 patients, and this area will be ready for next week. This is a big area for less severe patients, but eventually we can use it for monitored patients if we have the monitors available next week. Because I believe for physicians, it would be easy to work in a huge space than in a conventional respiratory unit.
I have a couple of comments. In each hospital, we are redistributing everything, opening everything that we can. But I like it, the concept on one hand, to the transportation to another regions by plane using the military resources or by train. And I think this is an important point. We have not done this in Spain yet, or in Catalonia. Well, in Catalonia, more or less, yes, but not by plane. But I was wondering if this has the risk to spread the infection.
Julian, what do you think? I guess the simple answer, it has the risk. Yes, I suppose that what we have to do is minimize that risk.
Certainly, you're totally right. There is a high risk to accelerate the spread of COVID-19, and we hoped that the high-speed train would go faster than the spread of the infection, because let's say in 5, 6, 7 days, the hospital at the western part of France will face the same hurricane as we know for now in the eastern part. So this is some kind of solidarity between hospitals in France and our colleagues from the west border of France. They knew at that time that they would have to face the same large wave, but at the time when they accepted the patients, they were not so impacted by COVID-19. So they offered this possibility, and we were very happy to profit by it.
Okay, thank you. Right, look, we need to draw this to a close because the 2 hours is just about up. I just want to make one other comment very briefly about an issue that a number of people have raised, and then just try to very briefly sum things up. Question a lot of people are asking is, what about existing patients on home mechanical ventilation who are being admitted to hospital in the middle of this epidemic? And I guess from my perspective is that they need to be treated in just the same way as the COVID-19 patients, in that they may or may not have the disease. If they do need to come into hospital for other reasons, then the only thing probably that we need to change is to change their vented mask to a non-vented mask. Has anybody got any very brief comments about this small group of patients who are causing some concern amongst our community?
Mark, I completely agree with what you said. I want to make another comment, which was made to me by a geriatrician, is that we have to stop everybody becoming COVID blind. And what that means is not everybody coming in is going to have a problem related to COVID. And I think that's a really clear message. Yes, we've seen some unusual presentations. We've seen some perforated colons. We've seen neurological presentations. But what everybody's got to watch out for is not thinking that everything coming through the door is COVID.
Absolutely, thank you. That's a really important point, Nick. And I mean, I guess some of these are people with other conditions who happen to be COVID positive as being a very minor part of things. Okay, well, look, just to try and draw this to a close and to put at least what I've kind of taken out as the key points for me, really focusing particularly on the role of non-invasive ventilation, CPAP, etc., is that if we use this, CPAP or NIV, it needs to be a short trial, 6 hours maximum. If patients are clearly deteriorating, that is easy, that the decision needs to be made between palliation or intubation and mechanical ventilation. I am still not entirely happy that I'm clear about what we regard as an acceptable response to CPAP. I can see that people who have a big response, that's fine, but it's that grey area where they're hanging on and they can keep hanging on for days, when actually maybe we should be cutting our losses and intubating that patient, because we run the risk of doing them more harm than good. And I think that this needs to be a real focus of both our thought and potentially research, that there are beginning to be a number of research protocols put together, studies up and running, and I think this is a really relevant issue. I think we also need to think in that group, because I think in our particular part of this is the biggest issue, is how long do we keep going with CPAP in a patient who is for palliation? If that patient is going to die at the end of this process, we are not doing that patient any favors. We are not doing our staff any favors, because we are subjecting them to aerosol generating procedures. We are depleting the hospital of oxygen that could be used for other patients, of interfaces, etc., etc. And I think that very quickly we need some clarity about these, and maybe these can be a focus of a further webinar if Philips are going to run this again, and perhaps focusing on some other issues like the use of ECMO, perhaps a little bit more about advanced care planning, etc. So I think with that, we'll draw things to an end. I'm going to try and produce a summary document from this, which I may well get back to you for comments about detail where either it wasn't entirely clear to me during the presentation, or where I just felt a little bit of extra detail from you might be useful. And we'll finish by just saying thank you very much for attending. Is there anything else anybody wants to say in conclusion?
That was brilliant and well chaired. Herding cats is a difficult thing.
Thank you. Thank you,
Okay.
Mark.
Well, thank you very much for coming, and thanks for all your insights, expertise, colleagues around Europe, colleagues in China who are coming out the other side of this, showing us that actually there is light at the end of the tunnel, that this disease can be beaten. So thanks very much.
Thanks so much.
Thank you to all the speakers for their informative and practical insights on managing severe COVID-19 patients. As a trusted leader in respiratory care, Philips is vigilantly working to help inform, provide for, and empower healthcare providers, clinicians, and all those impacted by COVID-19. Because at Philips, we're committed to our mission of improving lives, and our passion is intensified in these challenging times. And now, this does conclude our session for today. Bye and take care, everyone.